So far, we talked about the assessment, diagnosis, and treatment planning section. I'm just going to show these slides so you can see them. We talked about them already. This is what we're going to be going over. We talked about the biopsychosocial framework and how it's a holistic view of working with individuals. And we have the biological components. We always want to rule out medical before we start labeling people with a psychiatric or psychological issue. All right, so we were right here talking about medical mimics. So we talked about how these things can mimic other things. Hypothyroidism mimics anxiety. Hypothyroidism mimics depression. Vitamin B12 deficiency, it can mimic dementia and psychosis. So really, really important. You also have that urinary tract infection. I told you in the elderly, they're always present with hallucinations, confusion. I don't know if you guys are Chicago Med and Grey's Anatomy fans and stuff, but you know they have people that's common thing. Elderly come in and they have some confusion, some hallucinations, and they're trying to test and see what's going on, if they have dementia or what it is. And sometimes it can be as simple as a UTI. Sleep apnea mimics depression or ADHD. So please keep these in mind. A lot of times when it comes to these medical situations, they are sudden, atypical, and they occur a lot of times in older adults. So it's really important to look at this stuff first. Psychological components, right here is where we're looking at the cognition. We're looking at the emotional and behavioral patterns of individuals and how they function, how they're thinking, what do the symptoms look like, and any signs of trauma, anxiety. What is that person's self-perception? Do they feel like they're, doing well? What is their self-esteem, self-identity? These are just some key things that we're assessing and looking at when we're examining someone for their psychological components. We always assess both strengths and also symptoms. So you want somebody that's resilient, someone that's motivated. It's just important as pointing out all the things that the person has going on wrong with them. That is what we do as social workers. We come from a strength-based perspective. So we always try to find the good in our clients and bring that out as well, their strengths. It kind of helps through the whole process. All right, let's see here. Social components. Let's see all the stuff. We got the spiritual and cultural factors, social supports, housing, employment, finances. Yep, you guys got it. The social environment can amplify or buffer biological and psychological stress. So we always want to evaluate a person's environment and looking at that social piece. All right, so let me go ahead and have someone answer this question. Let's see, for some reason, my screen, I know I done called in everybody whose faces I can see who have their camera on. So let me see if I can switch and pick somebody. Let me see, Kayla, I don't know if I called in you, so I'm gonna call in you, Kayla, to go ahead and read this. You like, yes, I did, it's fine. I'm gonna start calling everybody twice because that means everybody else either don't have their camera on or Zoom doesn't want me to see them because I can only see the same, group of people. So go ahead, let me let you go and then I'll try to see who else I can pick on.
All righty. It says a social worker at a senior center is assessing an 82-year-old client. The client's daughter reports that her father was completely fine 2 days ago, but suddenly became highly confused, started seeing things in the room that aren't there, and is having trouble following conversations. What should the social worker do first? A, refer the client to his primary care physician for an immediate medical evaluation. A, administer the the MSE to assess for major neurocognitive disorder. C, screen the client for late onset schizophrenia. Or D, notify the family that, I can't see that part, help develop
that he has developed dementia.
Okay, I would say A.
Okay, you're gonna say A, refer the client to the primary care physician for immediate medical evaluation. All right, that's what we're going with. You're going to say A. Anybody else thinking something differently?
No.
My first thought was
B. D.
I'm going to highlight that I did say B.
I'm saying B.
If this was the test, the person that said they're going to highlight that they did say something, if you were taking the test, what are you going with?
I would have did B.
Okay. And anybody else picking A? It's between A and B, it looks like right here.
I went A. I went with B first, but because it says started seeing things in the room that aren't there, then I thought, okay, maybe it needs to rule out any kind of medical concerns.
All right, let's see, because you gave us a whole breakdown. And the key is someone said this. A few people have said this as well when you were wrestling between, I think someone said they were picking between, I think it was B. Let me go back and look at it. Administer the mini mental state exam to assess for major neurocognitive disorder. So I think a few people picked that one, and then a few people picked refer to client for primary. I think those are the main two. All right, let's see. Mental status exam. For those of you who do not know what a mental status exam is, it is pretty much a way that we can get a snapshot of what's going on with that person mentally. It is not meant to take place of giving someone a diagnosis, but it does help us formulate a diagnosis. So you ever hear someone say they oriented the person, place, time, and situation, or the person was disheveled, or they had rapid speech, they're pulling this information from a mental status exam. So it's really important to understand that. The appearance, the person was malodorous, because another mal word, a person is malodorous, meaning they had bad odor. Someone had poor hygiene, or someone was, agitated, they weren't cooperative, they had pressured speech, low tone, they were incoherent. Like, these are the things that you're going to be pulling from when you do a mental status exam. All right. And then when you do the mental status exam, just remember that is going to help you. So if you think someone has schizophrenia, or you think someone has depression, when you're doing a mental status exam, you can ask certain questions that's going to help you confirm or have a better understanding whether it could be that. That's not what you're going to use to diagnose them, but it'll give you some context of what's happening. And then you would use that along with what the client is sharing, your DSM-5 and all that other stuff. All right, so let's see here. We have a client, Trello. Do you want to read this question for us?
A 45-year-old client presents with complaints of feeling down and low energy. For the past 2 months, the client reports significant unintended weight loss and difficulty sleeping. The client denies any recent life changes or trauma. So A is complete a comprehensive suicide risk assessment. B is refer the client for physical examination. C is begin a cognitive behavior therapy for depression. And E is explore family history of mood disorders. So it says they present with complaints. So it sounds like they may be like in the assessment phase or in the beginning stage, and they come in with low energy. So, and they've been down for the last 2 months. I would not begin CBT, because that's starting with, well, for depression, that's the intervention. Okay. So I'm trying to see the stage that I am in. And when it says they present with complaints, so a lot of times when you present, you're in the beginning stage, like in that engagement.
Okay.
Is what I'll look at. So I think we're still in the assessment phase. It's been 2 months, but they're not giving a red flag that there could be a suicide risk, but it is depression and that. So I wouldn't go exactly with the risk assessment right away.
So let's see. So is anybody else? I've seen a few answers coming in there. B looks to be the most common one that you guys are going for. So let's see. The dead giveaway was a significant weight loss. It didn't say they were losing weight. It says significant. So clearly they shedding some pounds. It's not like, 3-5 pounds. Significant means a lot more. And the fatigue. And to me, one of the things that stuck out is that they reported not having any like major events or anything happening recently that kind of bring on some stress or something to kind of let you know something else going on. All right, let's go on to the next question.
It says a 35-year-old client presents to therapy reporting panic attacks characterized by a racing heart, sweating, and feeling of impending doom. The client states these symptoms began 2 weeks ago, shortly after receiving a major promotion at work. So what should the social worker do first? So starting first where the client is, want to get more information about what the symptomology that they're feeling. So I would go with B, to explore the stress and pressure related to the new job promotion and validating their statement, what they're saying.
Where does it say that at?
Oh, no. I'm using
you're adding stuff. Adding
I'm just thinking to myself of going with B to explore the stress and pressure related
adding stuff.
Okay, so we're just sticking with B. We're not saying validate all the other stuff.
No. I'm just in my head thinking this through.
Okay, no problem.
I'm going to go with B.
Okay. All right.
Yes, C.
All right. Anybody else? All right. Let's see what is.
All right.
Yep. Verify recent medical workup.
That makes sense.
All right. So culture responsive and trauma informed assessment. For this section right here, the religious and spiritual assessment, keep in mind, religion is an organized system of beliefs and practices, often includes dogma and specific rules. Spirituality is a personal search for meaning, purpose, and connection to something larger than oneself. So it may or may not involve religion. So keep that in mind. You ask your client, are you religious? So you consider yourself here. They might say, I'm spiritual. So have an understanding between the differences of those. And then you also want to assess for protective factors. Normally when someone is religious or they are spiritual, it gives them a source of hope, comfort, meaning. They have a connection. They normally have some positive coping skills and ways they handle stress. You want to also assess for risk factors. Trauma-informed assessment, 6 core principles. These are the things you want to look look at. You want to know whenever you're dealing with trauma-informed care, you have safety, trustworthiness, peer support, collaboration, empowerment, and cultural safety. So look at the bottom of these, because you guys know what safety is and trustworthy. Look at the exam tip. Safety is always the first priority when you're dealing with trauma-informed care. Transparency equals trustworthiness. Always explain what you're doing and why. You don't want to just go in there and start asking the client questions and assessing or doing certain techniques or interviewing styles, and they don't know what's going on, especially when they're all clients, but when clients are dealing with significant trauma, you have to build that trust first before you jump in and start, doing certain things. Transparency equals trustworthiness. Another one, peer support equals shared experience. They feel like they can connect with people who have been through what they've been through. Collaboration, doing with is collaboration, doing to is more like a parentified thing. Like, we don't do that. We don't want to tell the client what to do. We're not their parents. We're not the boss of them. So we definitely want to collaborate with them. And the exam has a lot of collaboration questions. So that's the key that you want to know. We do a lot of collaboration in social work. Empowerment equals the client's voice and the client's choice. So voice and choice for empowerment. Historical trauma is a valid trauma type when it comes to the ASWB exam. So make sure you're looking at that for like cultural safety, genocide, you have slavery, different stereotypes, race, religion, like all of this stuff is being factored in and considered when you're working with clients. So ASWB wants you to know that they recognize that as well. All right, cultural competency versus humility. We talked about this earlier inside of the human development section, but this is a little check mark that you can give yourself. What cultural competence focuses on, acquiring knowledge, and cultural humility is lifelong self-reflection. I'm learning from you and I'm open is cultural humility. I know about your culture. I studied and took a few tests on how you guys do a thing. That's cultural competence. So it's a difference there. And cultural humility is what the exam favors. All right, cultural balance syndromes. How many of you remember seeing these on your exam? Had a lot of people tell me they've seen these on the exam, so I have made sure to include it. These are cultural balance syndromes. The one that's not up here is, I always hear in the African-American community, when people are stressed out and going through a lot, they be like, don't stress them out, you're gonna give them a nervous breakdown. Nervous breakdown is not in the DSM-5, but that to me would be the closest thing to a cultural balance syndrome in that community. Here you have ataque de nerviosos. I always have somebody that corrects me, so if I have anybody who speaks Spanish and you wanna pronounce it correctly, please jump on and share it.
Ataque de nervios.
Thank you. Yes, every time. See, it wouldn't have been a boot camp if I didn't have somebody tell me how to break it down the correct way. I should know how, but at this point, I just love to hear you guys say it the correct way. All right, so that is pretty much an intense emotional upset, screaming, crying, trembling, heat in the chest, often triggered by family stress. That to me, it sounds like a nervous breakdown that we would use the example of, but we didn't make nervous breakdown didn't make it into the DSM-5, but these have. So these are examples of what cultures deal with. So for instance, if you have a client and they're trembling, crying, screaming, and dealing with this is not something where you're going to say, oh my God, this person's needs to be hospitalized or we need to get them checked out. It is a cultural balance syndrome. It's something that is culturally acceptable and norm in that culture of how they deal with ongoing stress. So you have to acknowledge that. That's having cultural humility, realizing and understanding that's a common thing for that culture and how to, move forward. And then you have the several other ones. These are just the most common ones, but there are quite a few. And these are located in your DSM-5 TR. I don't think you need to go that deep, but it's just important to understand that there are some cultural syndromes, and these are the ones that are likely to share. And I've had several people tell me that they've seen these pop up on their exams, probably more for the LCSW exam. All right. The cookie cutter trap. You want to avoid rigid standardization. So you don't want to just kind of adhere to doing everything a certain rigid way or through a certain model. You want to embrace that is a huge thing with ASWB now. They're really big on us meeting where the clients are. We've always said that as social workers, but now if you understand the verbiage, the words, and how the questions are tailored with the cultural humility versus cultural competency and trauma-informed care, is really connecting and meeting the client where they are and tailoring our interventions to that client and what they have going on. That is huge. So when you're answering a question, your questions and the answer to your question have to meet this standard. So it says if an answer choice suggests adapting a standard treatment to fit the client's needs, it is almost always correct. That is what they're leaning towards. We want to meet the clients where they are and adapt how we've been doing the thing to what's most appropriate and most helpful to the client. Interpreter, all the time. Before we even go through this slide, does anybody know what to do with an interpreter, how you handle interpretation? You have a client that speaks another language. What do you do? Do you try to pull up Google and have them speak into it and listen to it? Do you have the child join the session, or the spouse or someone that can kind of help you and give you some guidance?
In my experience, when I have a client who does not speak the same language as me, depending on the setting, like if I'm in a hospital, we notify there's a department that has an interpreter services, so we notify them.
Well, let me ask you in general, because I don't want to confuse people. I always tell people not to bring up what we do at work. What is the correct way according to ASWB of how we handle interpretation?
Get a professional always.
The person could have answered it. Who was answering?
Always have somebody on the outside come in and interpret it for you, rather than having a family or a child to do it, because you want to make sure that the information is being conveyed as what's being stated.
Yep. So professional interpreter. We avoid using family and friends. We never use children. Exception only permissible in immediate life-threatening emergencies until you have that professional person arrive. So obviously that would be obvious if it's an emergency situation, no one's there. But as soon as that interpreter comes, you would do that. So who do we speak to? If you're doing a session and you have the client there and the interpreter there, and the interpreter's kind of reiterating everything to the client, like who do you speak directly to, the client or the interpreter?
Client.
All right, so let's go ahead and do this vignette. Dami, I got Dominique and Dami. I thought y'all were the same. See, now I'm confused. I called Dami before, so let me pick on Dominique and then I'll come back to you. Y'all right next to each other now, and I got it in alphabetical order.
The question says, a social worker is attending a funeral for a client's family member. During the service, the client's aunt, who is Puerto Rican, begins screaming uncontrollably, crying, trembling, and falls to the floor. The family members surrounding her appear concerned but calm and do not call for medical assistance. What should the social worker do first? A, call 911 immediately, as the woman may be having a seizure. B, assess the woman for signs of a brief psychotic disorder. C, assess the behavior within the context of the client's culture. Or D, remove the client from the room to prevent secondary trauma. My answer would be C, assess the behavior within the context of the client's culture.
My answer is C, assess the behavior with the context of the client's culture.
All right, so we're doing another one. Let's see what this is. A 65-year-old Latina client presents for an initial assessment. He speaks limited English and has brought his 19-year-old nephew to translate for him. The nephew says, I can tell you everything you need to know about my uncle. What should a social worker do first? Should they proceed with the assessment using the nephew as an interpreter to build rapport? Should they thank the nephew but explain they need a professional interpreter? Should they assess the nephew's English fluency before deciding whether to use him? Or should they ask the nephew to wait in the waiting room immediately?
B.
Now, Dami, you can answer this one. I'm sorry, because I didn't.
I would pick B.
B, thank the nephew, but it's thank you, but I think not. We're going to get someone else. Let's say first. So basically B and C are the same thing. We're just kind of, no, we're not going to read into it. But yeah, B is thanking the nephew, but explaining, hey, we're going to need a professional person. D is asking the nephew to go wait in the waiting room immediately. And C is assessing his ability to speak English fully. And A is just moving on with the assessment. Does anybody think something different? All right, B is the correct answer. Now, D is interesting. I wanted to read the rationale for this one. It says, why D is incorrect. Immediately dismissing a nephew without explanation is abrupt and culturally insensitive. So obviously, I know you guys knew that, but I want you to understand they throw questions in there all the time like that. It's really immediate. Or you hear things like definite or always or must or, certain terminology was just like so forceful. So in this one, it was like immediate. If you ask them to go wait in the waiting room, but explained it, it's not wrong, but it's immediately you wouldn't do that. There's some things that you would say or do first, and then you would ask them to probably go wait in the waiting room.